Hi, and welcome to Rad-Onc Talks, a lecture series designed for students and residents of radiation oncology. My name is Ria. I am a PGY4 resident at the University of Pittsburgh, and this is our second installment of our gynecologic cancer series. In the first talk, we addressed some of the very general basics of cervical cancer, including workup, staging, and treatment paradigm. In this talk, we're going to dig deeper into the evidence behind cervical cancer management and discuss some of the seminal trials that guide our practice. If you recall from the cervical cancer overview lecture, we discussed that cervical cancer can kind of be divided into two buckets. The first bucket is very early stage disease that can be treated with upfront surgery, followed by tailored postoperative management depending on certain risk factors. And there are really two critical trials that guide our postoperative management for early stage cervical cancer after hysterectomy. So we will discuss those. Then we'll get into the trials that are more relevant to the definitive management of cervical cancer with definitive concurrent chemoradiotherapy followed by brachytherapy boost. And then finally, we will address some of the key pearls from EMBRACE studies that are really useful to us when it comes to treatment planning. So that first bucket of cervical cancer patients includes the very early stage patients that are amenable for upfront surgery. So I think of this as disease that's less than 4 centimeters in size and not yet invading into the parametria. Once it's greater than 4 centimeters or invading the parametria or beyond, it's a little bit too advanced for upfront surgery. So very, very early stage disease, they can be treated with upfront surgery. There are fertility sparing approaches, but most of the time the standard treatment is going to be a radical hysterectomy where we're dissecting the parametria as well and removing the upper part of the vagina, along with some type of surgery for the lymph nodes. And that could include sentinel lymph node biopsy or a pelvic lymphadenectomy. I think in the modern era, a lot of folks have moved towards sentinel lymph node biopsy. So radical hysterectomy plus sentinel lymph node biopsy. And ideally, after that surgery and the sentinel lymph node biopsy, patients can just be observed. However, if certain risk factors are present, then we may need to consider adjuvant therapy with either radiation alone or adjuvant chemoradiotherapy. So what are those risk factors and how do we decide whether patients should get adjuvant radiation alone versus adjuvant chemoradiation? The answers to these questions come from important clinical trials, which we will discuss now. Most of the trials that we're going to cover in this talk came from the GOG, which is the Gynecologic Oncology Group. So most of these are GOG trials with various numbers at the end of their name. The first trial we're going to talk about is GOG 92, and the first author on this trial was Sedlis, which is probably worth remembering and probably easier to remember than the number of the trial. GOG 92 ran in the late 80s and early 90s, and they took patients with stage 1B cervical cancer who had certain risk factors based on a prior study, GOG 49. The risk factors, which were the eligibility criteria for this study, are outlined in the table on the right-hand side. So they looked at 3 different things. They looked at the lymphovascular space invasion. They looked at the depth of stromal invasion. So they divided it into thirds, and middle or deep stromal invasion was considered a risk factor. And they also looked at the tumor size. Now, as you can see in that table, the LVSI, stromal invasion, and tumor size are kind of complicated to remember. A simplified way of remembering these criteria is that you basically just need 2 out of 3 of the risk factors. You either need to have LVSI, you need to have deep stromal invasion, which is middle or deep 1/3 stromal invasion, or you need to have a tumor size greater than 4 centimeters. That's a simplified way of remembering it. The table that's shown there is the way that it was actually included in this trial. But think of it as you needed to have 2 out of 3 of certain risk factors, and these are LVSI, stromal invasion, or size greater than 4 centimeters. And if they met these criteria, so if they had these risk factors, they were randomized to either radical hysterectomy with pelvic lymph node dissection or radical hysterectomy, pelvic lymph node dissection, followed by adjuvant radiation. These patients were just treated with adjuvant radiation to 46 to 50.4 gray to the pelvis, and no vaginal brachytherapy was allowed. The results of this study showed that there was a significant improvement in local regional recurrence as well as progression-free survival with the addition of radiation. So the 12-year local recurrence rate went from 31% to 18% with the addition of radiation, and the progression-free survival went from 65% to 78% with the addition of radiation. There was no significant benefit in overall survival, and the grade 3+4 toxicity was numerically higher in radiation, but again, it was not statistically significant. So 6% with radiation versus 2% without radiation. And so based on this trial, because it offered a local recurrence benefit as well as a progression-free survival benefit for patients who undergo hysterectomy for cervical cancer and either pelvic lymph node dissection or now sentinel lymph node biopsy in the modern era, if they meet these risk factors, which are defined as the SEDLIS criteria, because we know it has a local control and progression-free survival benefit, we offer them adjuvant radiation to the pelvis. So that's, nowadays we're doing 45 to 50.4 gray. Some folks will offer 50.4 gray to the postoperative pelvis just because there's a risk of hypoxia in the post-surgical environment. So an easy way to remember what the SEDLIS criteria are is SEDLIS, L-I-S. Remember the L-I-S risk factors. So LVSI, invasion into the cervical stroma, or size greater than 4 centimeters. So if you have 2 out of 3 of these SEDLIS criteria, L-I-S, that means that you might benefit from adjuvant radiation. And what is the benefit that adjuvant radiation provides? It's not an overall survival benefit, but it's a local control and progression-free survival benefit. The local control was improved from 31% down to 18% with the addition of radiation. Also keep in mind that these LIS, the 2 out of 3 for LVSI, invasion, and size, these are simplified criteria. The actual criteria are a little bit more involved, and I would look up that table whenever you actually need to look this up. But keep in mind that these are a simplified way of remembering the indications for adjuvant radiation after hysterectomy. The criteria for adjuvant chemoradiation come from the trial GOG 109, and the first author on GOG 109 is Peters. So we call these criteria the Peters criteria after GOG 109. So this study also ran in the early 90s, and they took patients with early stage cervical cancer, 1A, 1B, or 2A cervical cancer who had undergone radical hysterectomy and lymph node dissection. And in order to be included on GOG 109, they had to have at least one risk factor, either positive margin, positive nodes, or parametrial involvement. So positive margin is something that, at the time of surgery, if they're not able to get the disease out completely, and if the tumor extends right up until the margin, that's something that's found at the time of surgery. Positive nodes and parametrial involvement are basically functions of getting upstaged at the time of surgery, right? Keep in mind also that at this time they didn't have access to like MRIs and PET scans the way we do now. So they probably also had a harder time clinically staging these patients up front. So they were more likely to get upstaged at the time of surgery. But if they had positive margin or if they were upstaged with findings of positive nodes or parametrial involvement, they were included on this trial and they were randomized to one of 2 arms. So they either received adjuvant pelvic radiation alone or they received pelvic radiation with concurrent and adjuvant chemotherapy, which included cisplatin and 5-FU. So cisplatin and 5-FU were administered for 4 cycles every 3 weeks. So 2 cycles were given with the radiation, and then 2 cycles were given adjuvantly. And the idea for giving cisplatin and 5-FU with the radiation is for radiosensitization, so to kind of synergistically work with the radiation and help it have a better effect. And it was given every 3 weeks. So what they found is that with the addition of concurrent chemotherapy, there was not only a progression-free survival benefit, but also an overall survival benefit. So the 4-year progression-free survival went from 63% all the way up to 80% with chemo, so almost 15 to 20% PFS benefit. And then there was a 10% overall survival benefit where addition of chemotherapy to the adjuvant radiation improved overall survival from 71% up to 81%, so a 10% benefit. And they also saw that patients that had adenocarcinoma histology tended to have a worse prognosis versus squamous cell carcinoma. So that's something that we've realized is that adenocarcinoma tends to be a little bit worse prognosis compared to squamous cell carcinoma. But the bottom line from GOG 109 is that this study established the Peters criteria, which guide us in choosing patients that are candidates for adjuvant chemoradiation. So these criteria, remember the 3 Ps are the Peters criteria. So positive margin, positive nodes, and parametrial involvement. And I think of this kind of in the sense that if we knew before the surgery that they had positive nodes or that they had parametrial involvement, they would have been considered a higher stage anyway, right? Parametrial involvement, your stage 2B, positive nodes, your stage 3C. And so if we knew that before going into the surgery, they would have received definitive chemoradiation anyway, but instead they were thought to be early stage, went for surgery, and then upstaged at the time of surgery. And so now we're giving them concurrent chemoradiation in the adjuvant setting. The other thing that's important to realize is that, remember with the SED list criteria, we realized that radiation just had a local control and PFS benefit. It did not affect the overall survival. In the Peters trial, or GOG 109, the addition of concurrent chemotherapy does improve the overall survival. And I think it's pretty easy to think about why. Radiation is a local treatment, so we're providing a local control benefit. And we see that in the SED list trial, where adjuvant radiation is the only additional treatment, there's a local control benefit and a progression benefit, but not an overall survival benefit. With the addition of chemotherapy, we are now not only helping the radiation to work better, but we're also treating any potential microscopic disease that has spread distantly, right? And so that's why with the addition of chemotherapy, we are now seeing this 10% overall survival benefit as well. So that kind of wraps up the 2 studies I wanted to talk about for adjuvant treatment after surgery. Remember, SED list criteria, 2 out of 3, LVSI, stromal invasion, or size greater than 4 centimeters. We offer adjuvant radiotherapy alone. If people have Peters criteria, so positive margin, positive nodes, parametrial involvement, those 3 Ps, we think about offering adjuvant chemoradiotherapy with concurrent cisplatin. One other note that I'll make is that in the modern era, we don't give cisplatin every 3 weeks. We actually give it weekly, and the dose is 40 milligrams per meter squared. So the chemotherapy in GOG 109 was a little bit dated. We're not giving cisplatin plus 5-FU anymore, and we're not giving it every 3 weeks. We're just giving cisplatin 40 milligram per meter squared weekly. So that was adjuvant therapy. And we learned that sometimes, especially in the era that the GOG 192 and GOG 109 studies were conducted, sometimes staging isn't perfect, and patients might get upstaged at the time of surgery, and they might have certain risk factors like size greater than 4 centimeters or positive nodes or parametrial involvement, which lead us to want to give adjuvant therapy, either radiation or chemoradiation. Nowadays, with the utility of MRI as well as PET staging, we're better able to assess. It's still not perfect, but we're better able to assess the stage. And we know that if patients have higher stage disease, so if they have tumor greater than 4 centimeters clinically, or if they have parametrial involvement, distal vaginal involvement, nodal involvement, we know that these patients are a little bit too advanced for upfront surgery. And instead, we treat them definitively with chemoradiotherapy and a brachytherapy boost. So now let's get into some trials that guide our management in this setting. The first of these studies is GOG 123. And GOG 123 is kind of the rationale for why we are treating these patients with concurrent chemoradiation as opposed to just radiation alone. GOG 123 took patients with cervical cancer that measured greater than 4 centimeters, and they were randomized to either external beam radiation alone with a low dose rate brachytherapy boost versus external beam radiation with concurrent weekly cisplatin 40 milligrams per meter squared for up to 6 cycles. So that cisplatin dose of weekly cisplatin 40 milligrams per meter squared is what we are still continuing to give for radiosensitization. And they got concurrent weekly cisplatin along with the radiation. At this time, patients were still receiving extrafascial hysterectomy after that neoadjuvant treatment. In the next study, we'll talk about why adjuvant hysterectomy is no longer standard. But just remember, at this time, we were still doing that. It's not standard of care now. So these patients that had more advanced disease, greater than 4 centimeter tumors, when they were randomized to the radiation alone versus concurrent chemoradiation, it turned out that chemoradiation improved progression-free survival as well as overall survival. So that addition of cisplatin provided both a PFS and an OS benefit. Does that sound familiar? I think so. We saw the overall survival benefit with the addition of chemo in the Peters trial as well, right? GOG 109. And here again, we see that adding concurrent cisplatin provides not only a progression-free survival benefit, but also an overall survival benefit. So the PFS improved from 60% to 71% with chemo, and the overall survival improved from 64% to 78% with chemotherapy. These numbers, I think it's easy to remember. They're very similar to GOG 109. Just remember the overall survival went somewhere in the neighborhood of around 70% to somewhere in the neighborhood of around 80%, and both of those were significant. So GOG 123 tells us that concurrent chemotherapy with radiation improves PFS and OS in the definitive setting. I don't have a slide on RTOG 9001, but RTOG 9001 was an additional trial which, similar to GOG 123, compared pelvic radiation versus chemoradiation with concurrent chemotherapy. They used cisplatin and 5-FU, similar to GOG 109 in this setting, and they also found overall survival and disease-free survival benefit with the addition of chemo. So GOG 123 is not the only evidence we have. There's also RTOG 9001. Let's go back for a second to that question of why adjuvant hysterectomy is no longer done. Remember, we said in GOG 123, all of the patients were still receiving extrafascial hysterectomy, but that's no longer the standard of care. The reason for this comes from the trial GOG 71, which randomized patients with, they were randomized to either radiotherapy alone versus radiotherapy followed by an extrafascial hysterectomy. Keep in mind, in this trial, patients were not receiving concurrent chemoradiation because this trial was started at a time where GOG 123 and RTOG 9001 were not yet published. So they were just receiving radiation alone, and then either radiation alone followed by observation or radiation followed by a hysterectomy. And what this study showed is that there was no significant improvement in the progression-free survival or the overall survival with the addition of extrafascial hysterectomy. So there was no real benefit to the addition of extrafascial hysterectomy. And so what we've realized now is that if patients are already receiving definitive chemoradiation, we really don't need to pursue trimodality. It just adds toxicity, adds morbidity without actually providing a PFS or an OS benefit. There was an unplanned subgroup analysis of this study, which suggested that local control might be improved with the addition of hysterectomy if patients have larger tumors greater than 4 to 6 centimeters. And as always, unplanned subgroup analyses should always be taken with a grain of salt. But I think the big takeaway is that typically we are not doing adjuvant hysterectomy. It's something that can be considered if patients continue to have residual disease after chemoradiation and brachytherapy boost. So far we've talked about two very important trials that support our concurrent paradigm for the definitive management of cervical cancer with chemoradiation therapy. So we talked about GOG 123, that was the justification for treating with chemoradiation as opposed to radiation alone. And we talked about GOG 71, which did away with the adjuvant hysterectomy for the most part. We're typically just treating these patients with radiation and not offering them adjuvant hysterectomy standardly. Now, you'll notice that in some of the trials, the chemotherapy regimens varied a little bit, but we've been saying all along that the standard regimen is weekly cisplatin 40 milligram per meter squared. That also comes from level 1 evidence, and the evidence for that is this trial GOG 120 that compared 3 different chemo regimens given concurrently with radiation. So they took patients with stage 2B to 4A cervical cancer who were receiving radiation and randomized them to one of 3 concurrent regimens. So cisplatin 40 milligram per meter squared weekly versus hydroxyurea versus cisplatin 5-FU and hydroxyurea. The results showed that hydroxyurea alone was the loser. It had the worst overall survival and progression-free survival. However, both cisplatin-based arms showed similar outcomes. So cisplatin-based chemotherapy had superior progression-free survival as well as overall survival. And so based on this trial, when you have 2 different regimens that yield the same results, one has just 1 drug, the other has 3 drugs, it's a no-brainer. You want to do the simple thing, right, which is just to give the 1 drug. And so that is why the standard dose of concurrent chemoradiation is cisplatin 40 milligram per meter squared, and it acts as a radiosensitizer. It helps the radiation work better. And because it acts as a radiosensitizer, it's important to realize that when we're doing it with radiation, we like to have the cisplatin infusions scheduled towards the beginning of the week. If we schedule them towards the beginning of the week, then cisplatin is in the patient's bloodstream while they're receiving the radiation Monday through Friday. On the other hand, if they were to get it at the end of the week, Thursday or Friday, they're spending 2 days of the weekend where they're not getting any radiation and the cisplatin is in their system. So we try to time it so the cisplatin is given at the beginning of the week so that it's in their bloodstream during the week while they're getting the radiation. The other thing that's important to remember with cisplatin is that it's a chemotherapy agent, and especially given along with the radiation when they work synergistically, radiation can also affect blood counts. It can affect your lymphocytes, deplete lymphocyte counts. The chemotherapy can deplete your platelet counts as well. So it's really important to keep an eye on patients' blood counts. And if they do drop below a certain level, sometimes the gyn-onc that's administering the chemo may opt to hold the concurrent chemotherapy if the blood counts are dangerously low. If they're very, very low, then sometimes we need to hold the chemoradiation as the radiation therapy in addition to the chemo. Remember, we try not to interrupt the radiation just because we know that overall treatment time matters. Getting these patients done within, no more than 7 to 8 weeks maximum is really important otherwise there's a detriment to the local control. So we really try to get through without treatment breaks. But it's important to realize that, this can be a pretty toxic treatment and patients can get sick while they're on therapy. So it's really important to keep a close eye on them, make sure that we're checking weekly labs, make sure that we're repleting, electrolytes if they're down just because patients might have diarrhea with radiation. It's also really important to keep an eye on their blood counts and keep an eye on whether or not we need to be holding that concurrent chemotherapy. So that was a little bit long-winded into getting into an explanation of cisplatin and managing that during radiation. But the key takeaway is that GOG 120 compared a few different chemotherapy regimens. And from this trial, cisplatin 40 milligram per meter squared emerged as the winner because it was the simplest way to have the best possible outcomes. The last trial I want to talk about for the purposes of backing up our definitive management with chemoradiation and brachytherapy is the Outback trial, which looked at the addition of adjuvant chemotherapy with carboplatin and paclitaxel following chemoradiation with brachytherapy. So Outback, additional adjuvant chemotherapy, adding chemotherapy Outback. So this trial looked at patients that were undergoing definitive chemoradiation for cervical cancer, and in addition to the brachytherapy boost. And these patients were randomized to the standard cisplatin-based chemoradiotherapy with brachytherapy boost alone, or the standard therapy followed by adjuvant carboplatin and paclitaxel given every 3 weeks for 4 cycles. The results showed that there was no improvement in progression-free survival or overall survival with the addition of that Outback chemotherapy. The progression-free survival was just around low 60%, 61 versus 63% in both arms. And the 5-year overall survival was, just a little bit higher in the low 70s, 71% versus 72%. So this trial tells us that adding Outback chemotherapy does not improve progression-free survival or overall survival. So standardly, if we're treating patients with definitive radiation for cervical cancer, we're doing concurrent chemoradiation, and towards the tail end of the external beam portion, we're adding in that brachytherapy boost. And we looked at whether adding adjuvant carbotaxol Outback helps improve outcomes, and this trial was negative. So we are not standardly adding adjuvant therapy after the chemoradiation. So we've talked about a lot of studies now, and I just want to take a little bit of a break to give the major takeaways from everything we've talked about until this point, and maybe try to give you some mnemonics to remember these trials, because I think there are some boards questions that could show up where you actually have to identify the trial by its name, and it's very hard for me to remember all of these. So I've come up with some silly ways, and I'll try to share those in case it's helpful. So we first talked about patients that are early stage and amenable for upfront surgery, and there are certain indications for postoperative treatment with either radiation or chemoradiation. So GOG 92 gave us the SED list criteria for adjuvant radiation alone, and simplified SED list criteria are 2 out of 3 of the LVSI, stromal invasion, and size greater than 4 centimeters. And then GOG 109 gave us the Peters criteria for adjuvant chemoradiation, which were the 3 Ps: positive nodes, positive margins, and parametrial involvement. If you need to remember the stupid simple way that I remember the names of these trials is 92, if you draw a 2 backwards, it kind of looks like an S. And for 109, if you draw an N backwards, it kind of looks like the P. And then I just remember the SED lists and the Peters because the LIS are the SED list criteria and Peters criteria are the 3 Ps. So that's my silly way of remembering GOG 92 and GOG 109. Moving on to the definitive managements, when we're doing definitive chemoradiation, we talked about a few different trials. So 123 gave us the chemo-RT. Okay, 123 told us that chemo-RT with concurrent cisplatin provides a PFS and OS benefit versus radiation alone. So my little mnemonic is just like this little poem. GOG 123 gave us chemo-RT. GOG 71, we compared radiation plus or minus adjuvant hysterectomy. And this was a negative trial, so adjuvant hysterectomy did not add the benefit. So GOG 71 is why surgery is not done. Another little poem mnemonic. And then GOG 120 we compared cisplatin alone versus hydroxyurea versus cisplatin, hydroxyurea, and 5-FU. And cisplatin alone was the winning. It was the same as the cisplatin plus hydroxyurea and 5-FU, but giving weekly cisplatin alone is more simpler. And so that is why that is the standard concurrent chemotherapy that we do. So for 1-2-0, cisplatin was the hero. So that's how I remember GOG 120 compared all of those arms. 1-2-0, cisplatin was the hero. And then finally, we have the Outback trial, which I think this one, it's in the name. There's no benefit to adding adjuvant carbotaxol Outback. So adjuvant after the definitive chemoradiation. So those are my little mnemonics to remember these studies. 1-23, chemo RT, 71, surgery is not done, and 1-2-0, cisplatin is the hero. And then Outback, it's in the name. And remember, this was a negative trial, so no benefit to adjuvant chemo Outback. We briefly mentioned the EMBRACE studies in the talk on cervical cancer overview, which really give us a lot of good planning pearls for when we're doing chemoradiation as well as the brachytherapy boost. And so I just want to take a little bit more time and delve deeper into the EMBRACE studies and just share some of the data that has come out of them and how that guides and influences our treatment planning. The EMBRACE study group is based in Europe, I believe, and their prospective protocols, EMBRACE 1 and EMBRACE 2, have enrolled patients not only in Europe, but also in North America as well as Asia. Before the EMBRACE 1 data came out, there was a retro EMBRACE study that looked at patients retrospectively that were treated with cervical cancer. And this first analysis established a dose-volume relationship of tumor control probability. So let's break that down. The first thing they realized is that the bigger the tumor, the worse the local control, which makes sense. Bigger tumor, more aggressive, worse local control. The second thing they realized that also very much makes sense is the higher the dose to the tumor, the better the local control. So if we treat it to a higher dose, the local control is improved. The dose that we're treating these tumors comes primarily from the brachytherapy boost. So we can give external beam radiation up to 45 gray, and then we give an additional brachytherapy boost, and when we calculate the equivalent dose in 2 gray per fraction, we're almost doubling that dose, so taking it up to a dose of somewhere between 80 to 90 gray. And that was kind of the recommendation before Retro EMBRACE came out, to try and cover the high-risk CTV to a D90 of somewhere around 80 to 90 gray. With Retro EMBRACE, they actually established a minimum cutoff of 85 gray for the HRCTV D90, and a dose of 85 gray corresponded to a local control of 94% for tumors that were 20 cc's, 93% for tumors that were 30 cc's, and 86% for tumors that were 70 cc's. And in this analysis, they found that each 10 cc increase in volume required an additional 5 gray to achieve an equivalent local control. So basically, this is telling us that we should at least try to obtain an HRCTV D90 of 85 gray for cervical cancers. And so that comes from the brachytherapy boost combined with the 45 gray that we're delivering to the pelvis. If we're dealing with a larger tumor, then ideally we would try to increase the coverage to those larger tumors, because we know larger tumors are more aggressive. And in order to get the same level of local control, we need to kind of boost the dose a little bit further as we're able, without compromising toxicity, obviously. It's very challenging in reality to do that. But theoretically, if you want to improve the local control for these larger tumors, for each 10 cc increase in volume, we need to add an additional 5 gray for an equivalent local control. The data also told us that each week that we delay the total treatment time beyond 7 weeks, we notice a decrement in overall survival, and we need to add an additional 5 gray for equivalent local control. So there was an older retrospective study that gave us a time cutoff of 56 days, which corresponds to 8 weeks. And then based on retro-embrace data, that cutoff was shifted to 7 weeks, which is 49 days. So two important things from retro-embrace. Number one, our minimum target HRCTV D90 should be at least 85 gray. And then if we have larger tumors, we think about increasing that EQD2 even higher to get the equivalent level of local control. And then secondly, the recommended total treatment time is 7 weeks, which is 49 days. So subsequently, we started to see publications from Embrace 1, which is a prospective multicenter cohort study that enrolled patients, and they were treating patients with MRI-based planning using image-guided adaptive brachytherapy. So getting MRIs with every fraction and planning out the brachytherapy treatment on MRI. The advantage of MRI compared to using a CT scan is that on MRI, you're better able to delineate the soft tissue, so you're better able to see the GTV, the high-risk CTV, and you're also better able to actually see the organs at risk and contour them a little bit more appropriately. The downside with MRI is that with CT scans, you can account for the density, because that's what CT scan is based off of, the density of the tissues. So you can account for the difference in attenuation between the different tissues. With MRI, you can't account for that difference in attenuation of the radiation. And so for our brachytherapy calculations, we actually don't do that if we're doing, we typically don't do that. We just assume that everything is homogeneous. And given how strong the dose is and how sharp the dose fall off is, that's sort of adequate for our brachytherapy calculations. So anyway, utilizing MRI-based planning, they had this prospective study, and the outcomes were really good. They showed 92% 5-year local control rates with an average of around 7% grade 3 to 5 toxicity, depending on which exact toxicity endpoint you were looking at. So minimizing the toxicity, trying to maximize the local control. And with long-term follow-up, there were some key findings that I want to point out. So there was one publication that compared toxicity in patients that were treated to a pelvic dose of 45 gray versus 50 gray. And what they found is that the external beam radiation dose of 50 gray corresponded to worse grade 2 plus diarrhea. So the 3-year, so the long-term grade 2 or worse diarrhea was around 10% in patients that were treated with 45 gray versus 20% in patients that were treated with 50 gray. So the grade 2 or worse long-term GI toxicity kind of doubled with 50 gray versus 45 gray. The GI toxicity also actually increased with a larger lymph node boost volume. So if that lymph node was very large, you can imagine the bowel is getting more dose as well. But we can't control when lymph nodes are very large. We need to cover them and we need to treat them. What we can control is the dose that we're giving to the entire pelvis. And it turns out there's actually no data showing improved local control with doses above 45 gray. And now we have this data from Embrace 1 showing that the grade 2 or worse late GI toxicity approximately doubles if we use 50 gray versus 45 gray. And so the recommendation is typically to treat the pelvis to a dose of 45 gray external beam radiation in the setting of definitive chemoradiation for cervical cancer. Another publication that came out of the Embrace 1 data compared the outcomes for adenocarcinoma versus squamous cell carcinoma. They compared a few different risk factors, but what they found is that adenocarcinoma histology is actually associated with worse local control compared to squamous cell. And remember, that was seen in one of our earlier studies as well. I believe it was GOG 109, where they pointed out adenocarcinoma tended to have worse local control. So if they looked at patients that got an HRCTV D90 of at least 85 gray, that corresponded to a 95% 3-year local control for squamous cell carcinoma versus an 86% local control in patients with adenocarcinoma. So some practitioners might actually consider increasing their target EQD2 for adenocarcinoma versus squamous cell carcinoma. So aiming for something like 90 gray EQD2 if it's an adeno versus at least 85 gray if it's a squamous cell carcinoma. So that's just, more evidence. We already know this, but further evidence that adenocarcinoma is associated with worse local control. It's a more aggressive histology. So key takeaways from these publications that came from Embrace 1. Our standard external beam radiation dose is 45 gray and 25 fractions because 50 gray has not actually shown a benefit in any data that we have, and we know that it's associated with worse late GI toxicity. And then we also know that adenocarcinoma histology is more aggressive player, worse local control, so might consider aiming for a higher brachytherapy boost if it's adenocarcinoma. And then finally, we have Embrace 2. The protocol for Embrace 2 is available. I don't believe that there are any publications from this yet, but similar to Embrace 1, Embrace 2 is additionally a prospective study. I believe at this point it has completed enrolling patients, but we're just waiting for the results to be reported. But basically in Embrace 2, they took the data that they had from Retro Embrace and Embrace 1, and they derived a protocol for image-guided adaptive brachytherapy. But now we're in an era where we are routinely utilizing IMRT as well. If you recall from the overview lecture, we talked about the Time-C trial that showed an improvement in toxicity with IMRT compared to 3D. So we're routinely using IMRT for our external beam radiation, and we're also using image-guided radiotherapy. So Embrace 2 is really kind of pushing forward and establishing modern guidelines for brachytherapy for cervical cancer. So I just have some screenshots of dose constraints from the protocol. I think these are helpful references for when we're actually planning in clinic. And one thing I'll point out about the Embrace 2 study, in addition to their protocol, and they have, they're kind of pushing forward, pushing it at the front lines of brachytherapy for cervical cancer. And I think they are advising that we try to aim for covering the tumor with an HRCTV D90 of at least 90 gray as opposed to 85 gray. So that's something that they're investigating, and it'll be interesting to see the data that comes from Embrace 2. One other thing I wanted to point out is that Embrace 2 is investigating the role of prophylactic para-aortic nodal irradiation in patients that are pelvic lymph node positive. So just to give a little bit of background on this, when we're treating the pelvis for definitive chemoradiation, whether or not patients have lymph nodes, we're always going to do pelvic radiation, right? So that's going to include our common iliac lymph nodes, our internal and external iliac lymph nodes, the presacral lymph nodes, typically down to around S3, and the obturator lymph nodes. So that's kind of our standard volume for pelvic radiation, and there are contouring guidelines out there for that are good references when you're actually dealing with this in treatment planning. So that's our standard pelvic radiation. Now, if patients have para-aortic lymph nodes that are positive at the time of diagnosis, then we certainly will need to boost those and cover the para-aortic nodal regions as well. The question is there any role for prophylactic para-aortic nodal irradiation? And there is some data, retrospective data by Dr. Vargo at my institution where I'm training. And this was a retrospective study of patients with stage 1B to 4A cervical cancer treated at our institution. And they assessed patients with a PET CT, and patients that had PET positive lymph nodes in the pelvis were treated with extended field IMRT. So they sieved the involved lymph nodes up to 55 gray, and then they gave 45 gray and 25 fractions with concurrent chemoradiation to the extended field. So not just the pelvis, but also the para-aortic lymph nodes. Around 2/3 of the patients in this retrospective study had pelvic lymph nodes only, and around 1/3 of them had positive para-aortic lymph nodes as well. In this retrospective study, what they found is that for the patients that had para-aortic lymph node radiation prophylactically, so patients that only had pelvic lymph nodes positive and then had prophylactic para-aortic radiation, the rate of para-aortic failure was only 2.5%. Unfortunately, with cervical cancer, the majority of failures tend to be distant. So these patients tend to have distant metastases. But if we're prophylactically treating the para-aortic lymph nodes, it looks like we're definitely reducing their risk of para-aortic lymph node failure. There's a picture that I've included from another trial that came out of Embrace that looked at patterns of failure. And they found that patients with presence of common iliac lymph nodes, 3 or more positive lymph nodes, or bulky lymph nodes were actually at increased risk of para-aortic nodal failure. And you'll see that in that picture, if they looked at the location of nodal failure, a lot of these patients were failing. When they did fail in the lymph nodes, up to 68% of failures were in the para-aortic nodal chain. And so practice patterns can vary, but some physicians will actually favor treating the para-aortic nodes prophylactically, especially if there are high-risk features like positive nodes in the common iliac chain, greater than 2 or 3 pelvic nodes, large pelvic nodes. And I just wanted to point out that this is actually an area of investigation in Embrace 2. So hopefully when this is published, we'll have some further data to guide our management in this space. So that brings us to an end of our discussion of the evidence for cervical cancer management. As with any disease site, we're never able to cover every trial that has been done about that particular disease site. But I tried to include some of the seminal trials that are commonly tested, important to know. And a lot of these GOG trials are older. You saw, they were run in the late 90s. But they're still actually very relevant to our practice today, and they still are relevant in terms of the treatment paradigm for cervical cancer. So hopefully between this talk and the overview talk, you are able to get a sense of the general treatment paradigm for cervical cancer, and then some of the literature to kind of back up the reasons for why we do what we do. So I hope this was helpful to you, and thank you so much for your time and attention.